Hi, I'm Wayne Sullender from the Center for Global Health. Thanks for coming for today's lecture. I'm pleased to introduce Dr. David Kuwayama from the School of Medicine. He's an assistant professor of vascular surgery and has numerous experiences, including working with Partners in Health, Save the Children, and MSF. And if you saw the announcement, you also see that he has worked in Haiti, West Darfur, Sudan, and also in Central Africa, and he'll be speaking with us today about his experiences. Kuwayama, glad to have you here.
Thanks, Dr. Sullender, for the introduction. Thanks, Molly, for having me. I guess Dr. Berman's not here right now, I suppose, but I want to thank him for inviting me to be here today. My name is Dave Kuwayama. I'm an assistant professor of vascular surgery at the university, as Dr. Sullender just said. And today I'm going to talk to you about basically my other life, which sometimes I think about my job here at the university as sort of my side job. I think about the time I get to spend with MSF as my main job, because it's really what motivates me, and really what made me decide to go into medicine in the first place was to work with an organization like MSF. I've had the opportunity to go on a couple of missions with them at this point, and what I'm going to talk to you about today are some of the evolving challenges that I'm actually getting to witness firsthand now. The first time that I went abroad for any kind of significant international medical work was back in 2005, when I went with Paul Farmer's organization, Partners in Health, to rural Haiti for a year. It was sort of my indoctrination into international medical work. And since that time, I've had the opportunity to go to a couple of different kinds of projects and different kinds of contexts and environments. Most recently back from South Sudan in October and November of last year. But something that I've sort of been party to witnessing has been this concerning phenomenon that a lot of observers and participants in the humanitarian movement are feeling. And that's this gut instinctual sense that the humanitarian space, that the environment in which we can actually get meaningful work done for patients is narrowing. It's becoming harder and harder for us to do the job that we're there to do because of an evolving security context that is frankly worsening. And so I'm going to talk to you about that, and what I think we can do about it potentially. So I guess the primary questions with respect to that I kind of want to broach over the course of the talk here is first, where is this seeming insecurity stemming from? What phenomena are underlying it? Is it actually real? Or is it just something that we perceive but isn't actually a true phenomenon? Maybe the grass is always greener. We have it so hard now. Back in the golden days, it was so much easier. Well, is that true, or is that just sort of this sense that we have? And then, what solutions are aid organizations like MSF? I'm mostly going to talk about MSF because that's the organization I'm most familiar with. But what kind of solutions are they implementing at present to try and address those security issues? And what other solutions might there be on the horizon to hopefully more effectively address the conflict that we're facing between security and access to patients? So I really like this quote by William Shakespeare. I thought it sort of sums it up. Men in rage strike those that wish them best, from Othello. And if you look at the history of the modern humanitarian movement, it's really been walking in lockstep with the history of modern warfare. Humanitarians are basically stuck in an environment with people who, for whatever reason, are motivated by violence. It's the very nature of the situations to which they're responding is a violent situation. A lot of people date the beginning of the modern humanitarian movement to the founding of the Red Cross by Henri Dunant and Gustave Monnier after the Battle of Solferino in northern Italy in the mid-1800s. And that was clearly, the founding of the Red Cross is in direct response to a major battle where 40,000 people were either dead or lay dying on the ground. MSF was founded by Bernard Kushner and a couple of other French physicians in the late 60s, early 70s, and that was also in direct response to an armed conflict, the Biafran conflict in Nigeria, when the Nigerians were basically blockading or putting under siege this rebel province, and thousands of people were starving to death. And the impression of the French physicians who at that time were working for the Red Cross was that the response by the Red Cross was insufficient. It was not vocal enough. And so MSF essentially broke away as a splinter group and took another path. And you can basically go down the list of major humanitarian aid organizations that are at work today across the globe. And most of them, if you trace their genealogy back, you'll find at the root of their founding, whether it's the International Rescue Committee, any of the various UN refugee agencies, you'll find some kind of armed conflict that sparked their inception. This actually is Bernard Kushner back in the early 1980s. This was after he and some other French physicians basically snuck across the border from Pakistan into Afghanistan and were providing essential medical services and some basic surgical services to the Mujahideen in Soviet-controlled Afghanistan. And I mean, clearly what he was doing was highly dangerous. So from the beginning of the movement, it's involved exposing oneself and one's colleagues to an element of risk. This guy here in the bottom left-hand corner of the screen, he's a friend of mine. His name is Rogier van Helmand. And the reason I put a picture of him in there is because he's seen these kinds of security issues from both sides. So he used to be a Dutch soldier in a former life. And he was actually a Dutch peacekeeper in the Bosnian War. He was in Srebrenica in the mid-90s when things were falling apart. And so his tradition for how to stay safe, how to remain safe in this kind of context, comes from very much a military background. And safety in that context is force protection. And force protection comes from firepower, defensive power, and mobility. And you can see these kinds of convoys they traveled in. What's interesting is that while he was a peacekeeper there, he also had to interact with MSF, who was functioning in Bosnia at the same time. And what he found was that he was more at risk than the MSF physicians and medical staff. Anytime people were taking pot shots at the Dutch peacekeepers. Many of them were injured. Some were killed over the course of their deployment. The MSF physicians were able to move through checkpoints with relative ease. And what he found was that the MSF model, which was being there, being neutral, being impartial, and acting in the name of medical ethics for humanitarian purposes, was sufficient, if anything better, than what the Dutch mandate was at keeping them safe. So after he retired from the Dutch military, he actually started working for MSF. He's been on several missions, and he's now one of the lead recruiters in New York, the New York office. So if any of you ever apply to work for MSF, you may be talking to him. But so he's seen it from both sides, and every time he recruits people, he tells people that he's always felt safer in conflict environments in his role as a humanitarian than he did in his role as a UN peacekeeper, when you felt like a target. So I don't expect you to read this slide. This is but the reason I put it up there is to sort of reiterate that any major aid organization, MSF included, has put a lot of time and thought into how to remain safe in inherently unsafe environments. These are basically the golden principles, what MSF calls as golden principles of security. It's very well thought out. It includes very clear lines of command and communication, core benchmarks for what it takes for MSF to feel that it's in a safe environment and how to stay safe in that environment. But if I was going to redact this down to a few key points, these are the ones that I would take out of that sort of overarching document. So first, security for any MSF project comes from achieving wide stakeholder engagement. So really implementing the neutrality and impartiality by making it clear to all players in a context that MSF is there for all of them equally to provide care for whoever needs it on purely medical and humanitarian grounds. Second, having high quality programs that really do make a positive impact is key to safety. If you are being useful, if people see that you're saving lives, that they bring their child to the hospital and they get better, that inherently makes the project safer. Third is to trust individuals over processes. So the way that gets implemented is that they leave ultimate authority on security decisions to people on the ground, people who are in the know, the field managers, not the head honchos in Paris or Geneva who may be reading the news. They don't really know what's going on. Fourth, and I think very importantly, is that MSF does not consider arms, weapons, or for that matter, armed protection to be acceptable because they feel that it damages the very principle of neutrality and impartiality that makes it safe in the first place. So it's only with very rare exception that any MSF project would have anyone who is armed being present at the compound. But every time you ever see any kind of MSF vehicle, MSF compound, you'll see the big red circle. I think I showed you one there with the no gun sign. It's almost a universal MSF emblem. And then finally, MSF, while its primary mission is to access populations in need, it doesn't consider its presence there to be a mandate. It considers its presence there to be a choice. And so it reserves the right to withdraw and to leave a context without apology if necessary for security reasons. So for 40, 50 years, this has been the paradigm that MSF has operated under to remain safe. And some would say it's like waving the white flag. I'm a humanitarian. Don't shoot. Remarkably, it's worked quite well for a long time. But some people are starting to question whether, in the changing era of the last decade, and perhaps even more in like the last 5 years, whether there needs to be some kind of changes to this simplistic model. Because some of the fundamental underpinnings have also changed. The environment in which we're working is changing. Before I talk more about that, though, I do want to point out that silence in the face of injustice is not one of MSF's ways of staying safe. In fact, you'll notice that more than almost any organization, MSF is unashamed if it sees something that it considers to be a violation of fundamental humanity. They will go to the press. They will go to governments. They will speak out. And it causes a lot of stress and a lot of strife, because sometimes that does elevate risk. It's typically done in conjunction with a withdrawal from an environment. If MSF feels that it has to extract itself because by very force of presence it's condoning or helping facilitate some kind of injustice. And every time it happens, it's a huge debate within the movement. There's a very interesting website you can go to. It's called MSF Speaking Out. And this is just a handful of about 25, 30 documents they have there. Each one is a very detailed critical analysis of a fundamental decision point where MSF had to decide whether to keep working in an environment or to speak out and raise the risk profile. And it runs the gamut from North Korea to Chechnya, Somalia, Rwanda. Every time MSF has faced this decision, they do a critical analysis piece, and anybody can get access to it. I highly recommend it. They're very interesting. So why do I think things have changed recently, and what do I think has contributed to it? I'm going to just kind of start here with what I think has been a bit of a blurring of the lines around what it means to be humanitarian. So there's a disturbing trend in the late 90s, mid-2000s, where the US military and other Western militaries started incorporating humanitarianism, or what they called humanitarian goals, into their military intervention. And I think part of it was a byproduct of this nation-building phenomenon that we were engaged in, right? The idea was, let's come in, let's kill all the bad people, and then let's rebuild. We'll bring in schools, we'll bring in water and electricity, and then people will like us again. And frankly, it won't surprise you to hear that it hasn't worked so well in a lot of places that we've tried it. It's been a very challenging experiment for the U.S. and the West. But from the very beginning of this kind of combination approach, humanitarian NGOs have been extremely upset and skeptical about it. The prime example of it was in the mid-2000s in Iraq and Afghanistan. There was a model called provincial reconstruction teams, which basically had embedded humanitarian workers inside of battalions. And it was basically putting civilians, various NGO workers. MSF never participated in this, but putting them together. And so I draw that U.S. Great Seal of the United States there with the olive branch in one hand, or one claw, sorry, and the arrows in the other. The problem is that makes things very confusing for people on the ground to understand where the line gets drawn between who's a Western interventionist power there with weapons and who is there purely to help. I was actually part of a working group when I was a policy student at Princeton that focused on provincial reconstruction teams. And I put a sort of a key quote about the humanitarian space issue there at the bottom, but just to paraphrase. So NGOs question military involvement in reconstruction activities because of fears about the shrinkage of humanitarian space. And the other key part of this, they place their personnel at risk by blurring the distinction between combatants and civilians. So, I think that this sort of set the stage for people in a lot of conflict zones around the world to view humanitarians with suspicion. And essentially, to a degree, it becomes easier if you're a citizen in one of these countries to lump all Westerners together as foreign interventionalists, because it can be too hard to figure out who's on your side and who's not. I think many of you may recognize this image. This was the first high-profile beheading in Iraq back in 2004. This is Nick Berg. He was not a military individual. He was there to help rebuild Iraq. He was a radio control tower builder. He was helping with some projects to rebuild the infrastructure, doing nothing nefarious, right? Now you can argue that this phenomenon would have occurred no matter what, whether the military humanitarian collusion had happened or not. Perhaps this was just such a savage time that this would have happened regardless. But the point remains that this problem, which we're particularly seeing in jihadi-controlled areas of the world, being a humanitarian is no longer sufficient to consider yourself safe. Nobody in their right mind would go into ISIS-controlled territory today saying, we're just here to help. It is almost becoming irrelevant as a form of self-protection. MSF did a several-year retrospective review called Medical Care Under Fire, where they were trying to review incidents over the past 30 years and identify whether there actually has been a trend towards more violence. It actually was unable to identify a clear numerical trend towards overall increase in incidents of violence against humanitarian workers, but it did find that there was a worrisome new trend towards ideals, what they called ideals-based attacks, where humanitarians were being targeted purely because of this idealism against Western intervention, as opposed to a lot of the previous episodes of violence, which were either matters of convenience or robbery or theft, that there has been a more idealism-based methodology to attacks against healthcare workers. The other thing that this project suggested, though, is that there might be another side to this coin, and that is that we might be paying more attention to the events that are happening because of some changes in the structure of humanitarian intervention itself. And a big part of that is what we call professionalization of humanitarian work. It used to be that you're just a volunteer, right? That's what I am still. I just go, once a year to do work in a given project. But humanitarian aid is now becoming an industry, a multi-billion-dollar industry, and there are people for whom this is their profession. This is their day job, and along with that has come essentially a professionalization of security consulting, of implementing very strict security guidelines in a way that's akin to how a government might function or how a corporation might function. So there is a suggestion in this MSF report that there's also a bit of a decrease in what we might consider a risk tolerance, or what we consider acceptable risk, and that therefore whenever an event does happen against an aid worker, particularly an expat, a foreign aid worker, that it becomes a big deal in a way that it might not have been in the past. Now, this Medical Care Under Fire report came out 2 years ago, and clearly there have been another genre of attacks or incidents that have occurred over the past year, which appears to be more from governments or coalition forces that have been assaulting health facilities and healthcare providers in several different conflict zones. I'll talk about Kunduz. I'm sure everybody here has heard about the terrible event in Kunduz, Afghanistan that involved the MSF hospital there. But other areas that we seem to be hearing about every week are Yemen and Syria, where it seems like every time you check the BBC website, another healthcare facility in one of these places has been damaged or destroyed. In Yemen, over 130 have been struck over the past year, mostly by Saudi coalition forces attacking from the air. In Syria, there was a Physicians for Human Rights report that found over 240 health clinics have been struck and 700 medical staff will have been killed by the end of 2015. 90% of those attacks from the Syrian regime. I'm going to talk a little bit about Kunduz because it was such a traumatic event for MSF. It's still something that we talk about and discuss all the time. This happened in early October. Just to recap the details, there was a U.S. AC-130 gunship that was acting on the direction of ground controllers, I believe were Afghan ground controllers. Chain of errors. Despite the U.S. command knowing the coordinates of the hospital, it essentially strafed it into oblivion. People in the ICU burned to death in their beds, screaming. One physician who was running from one building to the other was decapitated by a bullet. At the end, 30 people were dead, including 13 MSF staff, 3 of whom were physicians. And you can see the destruction. At the bottom left there is the operating room where the ceiling panel fell onto the patient who was being operated on at the time, who died. So there have been calls since this event there have been clear and consistent calls from MSF for an independent investigation of this. General Joseph Campbell requisitioned a DoD report, which came out, and the findings of that report were that, I'll quote, human error, procedural missteps, and technical failures contributed to the attack on the Doctors Without Borders Trauma Center on October 3rd. This was a tragic but avoidable accident caused primarily by human error. Sounds like a admission of responsibility. Despite that, MSF has remained unsatisfied. They believe that it is impossible for those who prosecute a potential war crime to thoroughly investigate it on their own. And they've called for the International Humanitarian Fact-Finding Commission to take over the investigation. This is Jason Cohen. He's our executive director, also based in New York, and he wrote an op-ed in the New York Times. Highly recommend it. But as he states here, in the case of Kunduz, it is not our responsibility to prove that the United States military violated the laws of war or its own rules of engagement. It is the responsibility of the party that destroyed a fully functioning hospital to prove that it did not. And part of the reason that they are dissatisfied with the DoD report is that while the DoD report did suggest that the rules of engagement were not followed, what MSF believes needs to be investigated is whether those rules of engagement are compliant with the laws of war. And so it's not within the purview of the DoD to reassess its own rules of engagement, at least in the context of that report. And it's why they're continuing to call for international investigation. So, on the one hand, humanitarians are facing a degradation in their privileged status in these environments from insurgent groups who seem to be more willing to target humanitarians than ever before. And on the other hand, from governments who appear to now, with some degree of regularity, either intentionally in some cases or with negligence, also attacking healthcare facilities. It's almost as if the humanitarian space is narrowing from both sides. And so then the question that all humanitarian organizations, but particularly ones that focus on war zones, are now facing is how to solve this dilemma. What can be done to deal with this narrowing humanitarian space? And one thing I can tell you is that money is not going to be the solution. The solution to this is not financial. In fact, MSF as a movement is, if anything, too rich. And I can tell you that because at the General Assembly last year, I had to listen to the treasurer for 30 minutes talk about how we need to cut back on our advertising budget because there's too much money coming in. I'm not telling you not to donate. If any of you donate, I highly recommend you continue to donate. But the truth is that MSF has within its mandate, within its charter, it can accrue no more than 10 months of operating expenses. And in fact, the amount of reserves is growing to a level that we're actually starting to face difficulty in spending those funds on programs. Last year, there was a $250 million surplus. MSF doesn't want to be a bank. It doesn't want to hold your money in its savings account. It wants to be nimble, and it wants to spend those money on programs. So the question that MSF is, the trouble it's facing is not too little money. The trouble it's facing is how to use those funds in the context of more and more insecurity in a way that it can remain effective and provide high-quality programs while also staying safe. So I can tell you that this is part of the impediment. There is, unfortunately, but of necessity, a mindset that is growing within all major NGOs of institutional risk. There's this phenomenon of, or this concept of duty of care. Have you heard that term before? It's this idea that an organization is responsible for the decisions it makes, clearly, particularly when the decisions it's making are putting employees or volunteers at risk. And so as this humanitarian movement is evolving into a humanitarian profession, this is becoming more and more salient. The picture here on the bottom is a guy named Steve Dennis. He was an employee of the Norwegian Refugee Council, and he was shot by, who knows, in Dadaab refugee camp, Kenya. It's the largest refugee camp in the world, actually. And he was pretty badly injured. His leg was badly injured. He's still debilitated. But he sued the Norwegian Refugee Council for failing to protect him and take adequate measures to ensure his safety. I actually first heard about this on the bottom left of that. That's a fundraiser page. And basically everybody was getting links to this to help contribute to his legal prosecution fund that he could use to prosecute the Norwegian Refugee Council. I didn't contribute. I'm not saying he's a bad guy, okay? A lot of people supported him. You see he raised like $40,000, so some people think he's making a lot of sense, right? But, and he won. He won $500,000. So apparently the courts felt that he had merit too, and that the duty to care, or duty of care, was not being met by his humanitarian aid group, right? But this sets a precedent. Imagine that you are part of the management or leadership of a major international aid organization like MSF. I mean, every day you give people a plane ticket to go to a place that their parents are having nightmares about, right? So, I mean, how can you address these issues unless you go to those places? How can you help those who are in the greatest need? At the same time, it creates a logistic nightmare for aid organization leadership. So some of there's three primary techniques that are gaining traction within the movement to help address this insecurity, all of which have raised a lot of debate. One is this idea of remote control. So what that means is that a mission, say in Pakistan, or in tribal Afghanistan would not actually be staffed by expats, by foreigners. Instead, it would be more like money being funneled to national staff to a project, with MSF leadership being provided either through teleconferencing or telephone. And there are some concerns with this. At first glance, it sounds like a good idea, right? But there are some real potential downsides to that approach. One is that part of MSF's mission is to be there with the people. And if you're going to have a mission, but nobody's willing to take the risk, what does that say about what the organization is willing to do for people? It's part of, it redacts down to the témoignage or witnessing principle. It's not being met when you're having a remote control project. Another, which is even more insidious, is that what if a project is so dangerous it should be shut down? Apparently there's a stratification of whose lives are most important if you're not willing to send expats, if you're willing to pay national staff to keep working there, right? So those are the issues of remote control. The second concept is this idea of bunkerization. And I actually experienced this. I'm going to show you a case example of this. But the idea that it's okay to be there, but you shouldn't go outside your compound, right? You shouldn't ever be exposed to any element of the actual community. You basically hide in your compound or hide in the hospital and minimize any actual community relationship. There's a couple of problems with that. One is that community engagement for the long time has been the cornerstone of security. And the second is that it almost can have a neo-colonial appearance, right? Like the plantation manager staying in the big house, right? While other people are tending the fields. So that has its own issues. Another, and one that profoundly impacts me personally, is volunteer profiling. So having a mission with expats, but only certain kinds of expats. So, for example, a lot of MSF France's missions I can't go to. I would love to go to Syria. I actually got asked to go to Syria, but it was when it was before they even announced they had a hospital in Syria. They had a secret hospital in the north, and they wanted me to go, but I had just come back from the Congo, and I couldn't take more time. But once they went public with their presence in the country, they basically recognized that they couldn't have Americans or Brits or people from politically sensitive countries going to certain projects, because their presence would actually raise the risk profile of the entire mission, raise the likelihood of a kidnapping or something that would have enormous repercussions, not just for that individual, but for the entire intervention helping those people in distress. So there's the nationality issue. There's the gender issue. In certain conservative Muslim countries, they don't want to be treated by a female nurse or a female physician. And so there's profiling based on gender. And this happens all the time. This happens all the time in our projects. It raises a lot of unhappiness from people like myself. In fact, one of the first things they ask you when you, as an American, when you get signed up with MSF is, do you have a second passport? And I'm not ashamed to say I actually went to the Japanese consul here and asked if I could get a second passport. But the problem is, Japan has one of the strictest nationality laws, and if I got a Japanese passport, within 30 days I'd have to renounce my U.S. citizenship. So I was like, well, that's a little bit too much to do for MSF. But, yeah, so those are three basic concepts that MSF actualizes right now in high security situations: bunkerization, remote control, and volunteer profiling. So it's 12:42. I'm going to try to finish up in the next 10 minutes so that there's some time for questions. But I'm going to do a little case study of where I just came from, which is Unity State of South Sudan. So South Sudan has not been in the news enough. So if you didn't know much of what was happening, you wouldn't be blamed. okay? But it's the world's newest country. It was formed in 2011 by popular election that separated it from Sudan. And there was a lot of hope when it first formed. And it's very shortly thereafter devolved into the most gruesome, bloody civil war going on in the world right now. It's taken on ethnic connotations. In fact, if one side gains the upper hand, it could actually turn into a genocide, which I am concerned is on the verge of happening. The prize jewel of South Sudan is Unity State, which is where I was working, the town of Bentiu, because there's oil fields there. It's the only place that has oil. And it gets shipped by pipeline up through Sudan to the Red Sea. So the two major ethnicities there are the Dinka and the Nuer. The Dinka, by all appearances, have started winning. But it's still a war of attrition. The problem is that neither side has sufficient materiel and logistics capacity to mount a death blow. So it basically turns into this, it's almost like World War I phenomenon where like the lines are moving, but nobody's actually gaining the traction to finish it off. And it's also hampered by rainy seasons that shut down the ability for military action for about two months. And so when I arrived, it was just at the end of the rainy season, and the military action was ramping back up again. In fact, I was seeing planes landing with military formations heading south, getting ready for the next offensive. In the context of all this, there are about 100,000 Nuer who saw the Dinka wiping out their homelands, and they fled to the nearest UN base. And the UN had no choice but to let them in. And what you see, it's basically a tent city. It looks like this from the air. I didn't take that photo, but that is Bentiu Protection of Civilians Camp. It's the technical term for it. They're internally displaced people. And the conditions are abysmal. The sanitation is horrific. Malaria is everywhere. Tuberculosis is everywhere. Malnutrition is everywhere. Particularly malnutrition, I want to talk a little bit about this because you may be hearing about this in the next few months in the news. So South Sudan, particularly Unity State, is on the verge of famine. In fact, there are 40,000 people right now that are considered at imminent risk of death because of lack of food. Twice a week, I would watch these planes flying overhead, dropping food into the wilderness, into spots for people to pick them up. Because what's happened is when the Dinka military came through, the Nuer had to flee into the swamps, and in the process missed the planting season. Right? They couldn't plant their fields, and you only get one shot a year, right? So they're basically, they have no food. They're entirely dependent on airdrops to survive. A large percent of the population, millions. 1.7 million right now is the target population for these food drops. This was a picture I took in the hospital the first day I arrived, and I just saw this child laying on the ground in one of the tents. They had asked me to come see him because he had abscesses all over his buttocks that needed to be lanced. They were full of pus. The only reason he had them is because he was so malnourished, his immune system is no longer functional, and it basically can't fight off simple bacteria anymore. So I ended up having to do like 6 or 7 INDs on him over the course of 2 weeks until he died. So remember how I said I'm going to give you a case study on bunkerization. So this experience for me was basically that, but not because it wanted to be. And I'll explain what I mean by that. So MSF prides itself on independence. It would never intentionally work inside of a UN camp for protection. And it was not working inside of this UN camp for protection. We were working inside of this UN camp And the reason being that there were 100,000 people inside the camp. And if you don't work inside the camp, then those 100,000 people have no health care. And so our hospital was inside of the UN gates. In fact, on the way in from the airport, you see there's like, armored vehicles, protecting the perimeters. Very atypical situation for an MSF project. This is what the hospital looked like in the upper left-hand corner. In the bottom left-hand corner is our bunker. Because you'd think that if you were inside a UN camp, you'd be safe. But if you thought that was the case, you'd be wrong. Because what would happen is about once a week, people would sneak up alongside the walls of the camp, and they would fire indiscriminately machine guns into the camp. They basically just strafe the camp. And many of those bullets would come down into the hospital. And they would call an alarm, and we'd have to all run into the bunker, right? And what you see there on the right is that's Jean Stoll holding the sheet of paper. She's the project coordinator, and we are laying out our triage plan. So because we know that as soon as the bullets stop flying, people are going to start pouring into the hospital with gunshot wounds. So the idea is having everybody with stations to run to help manage the influx of people. Security had to be very tight. Like I basically lived in the hospital. I went out once into the camp itself to see what the living conditions were like, but it was essentially like being bunkerized. That was the functional reality of it. Now this guy down here is a swell guy. His name is Rob Allen. He's British. He's actually a former British SAS, but turned humanitarian. And he told me I could talk about him, so I'm not releasing any secret information about him. But he was in a project just south of Bentiu. He was in a hospital called Gier. It's about 100 miles to the south. And they basically got ransacked by rebels, Dinka rebels. Basically destroyed the hospital. And these guys had to flee into the woods to save themselves, Rob included. I first met him in Bentiu, and he was messed up. Let me just put it that way. I mean, I'm not a psychiatrist, but he had PTSD. I mean, startle reflex, nightmares. He was messed up. In fact, he got sent home halfway through my mission, and he's doing fine now, right? But the reality is that there's a reason that people get bunkerized. It's because if you're not, then you're exposed to, you can be exposed to serious violence. So the reason that bunkerization was such a problem for me was that I found that being geographically close to people who were suffering war wounds didn't really matter. Okay, so what do I mean by that? So inside the camp, 100,000 Nuer. Outside the camp, Dinka military that basically would like to annihilate it if they could. The front line down by Gier, outside of which are lots of Nuer soldiers, lots of Nuer civilians, many of whom need medical care badly. The only way for them to get to us would be by sneaking through enemy lines under cover of night to get to the hospital. Many of these people would take 2 weeks after an injury to get to the hospital, when you could drive it in like 4 hours. But it would take them 2 weeks because they have to crawl at night to get to us. I wanted us to go out there. I wanted us to go back to Gier. I wanted us to invest the resources to head back out there. I volunteered, and They said it's just too unsafe. You know, they just weren't willing to expose manpower to that level of risk. But as a result, you know, the way I say it, I flew 10,000 miles to get there and fell 100 miles short. It's like I felt like most of the people I needed to help I couldn't get access to. This guy down here in the bottom, he doesn't like his picture taken. All I know is his first name, Luigi. He wouldn't tell anybody his last name. I had to kind of sneak him into the frame to get a photo of him. He's one of MSF's fixers. So he's one of these like nameless, faceless guys who's supposed to negotiate access for us. The problem in a place like South Sudan is that nobody's in control. He would go talk to a central governor in Juba, and they would say, okay, yeah, you can go into this part of Unity State. Then you'd go talk to the provincial governor and say, I don't know what you're talking about, you can't come here. Or the provincial government would say, okay, you can come here, but next thing you know, there'd be a military blockade. You know, you can't come here. Because there's no chain of command. It's almost totally lawless. And even if there is a chain of command that makes its way down there, you may be facing some child soldiers who are high on drugs. I mean, do you really think that they know what their marching orders are? All they know is they see some white guy, and they just want to like take your shirt. So, you know, we were functionally bunkerized. And I apologize for the graphic pictures, but I just want to show you what it looks like when somebody has a war wound and it takes them 2 weeks to get to medical care, right? This guy on the left here had his leg blown off by a rocket-propelled grenade. When he came in, it was covered in mud, sticks, and maggots. The guy on the top left had his zygomatic arch blown off by an AK-47 bullet. The guy on the bottom right there, through injury, shattered his radius and his ulna. That's also an AK-47 wound. They made it with some makeshift splint they made out of popsicle sticks. But, you know, I wish that we could have been closer to these people in providing care, but instead we had to sit back in our bunker and wait for them. So I have like 5 minutes left. I just want to point to some sort of like an evolving discussion within the movement that I've been part of. This guy's a good friend of mine. His name is Dave Elliott. He's a former military surgeon turned MSF surgeon who was based out of Virginia. And we've been having discussions about whether we think we are doing right in these kind of conflict zones the way we're currently implementing our projects. A lot of what we do now is hospital-based. We look for a hospital and we take it over and we provide services there. Right? The problem is that hospitals can get overrun and you have to evacuate it. It's a fixed infrastructure system. So, you know, this quote from Dave, I have read one statement by MSF International President Joanne Liu declaring that the MSF Kunduz Hospital provides state-of-the-art trauma care. But I would argue that in 2015, battlefield trauma care is not state-of-the-art unless it is mobile. And so the discussion about the next steps, right, and things that, discussions that we actually had in the field, things like implementing helicopter airlift capacity. For when you can't have a fixed infrastructure in a conflict zone, we'll scoop and run, clear an LZ, centralize some casualties, land, scoop, and get out of there. The military, the U.S. Army, has these things called FAST, Forward Army Surgical Teams, or Forward Mobile Surgical Teams, which are basically 4 Humvees that can deploy into a mobile hospital in under 2 hours. It can be broken down in the same amount of time. So these kinds of technologies for being mobile and functioning in these kind of environments exist. The question is whether NGOs are going to be willing to invest in it. This is part of the reason they don't want to, right? Helicopters get shot down in these kinds of environments. This is a UN helicopter that got shot down in South Sudan like 6 months before I showed up. So just because you're in a helicopter doesn't mean you're safe. In fact, there's this feeling that because it's pseudo-militarizing, it may make you more of a target. So I'll just close by saying this. You know, it's a dangerous world out there. The privileged status that humanitarians have had appears to be weakening. It's a combination of governments that either don't like us or don't care, and armed groups and militias that either don't care or actively want to destroy us because of our nationality or what have you. I think that the illusion that there can be any safety in a war zone is just that, it's an illusion. And I think that people who are going to sign up and work for these organizations, even if you're going to be a lifer, you have to accept that. And I think that that has to be a louder discussion inside the movement. I'm not blowing off duty of care, but it has to be within the context of what we're actually doing and where we're doing it at. And that we need to always be focused on safety, but we can't lose sight of our primary mission, which is accessing patients in need. I think that some of those novel ideas that are getting floated around there, they're going to be very cost intensive. Only a very small number of groups out there are going to be able to do it. I think MSF is one of them. I mean, MSF, you know, it's over $1 billion budget line. I think they were one of the few that could invest in it. So thanks for your attention. Yeah, appreciate it. And, happy to answer any questions.
I have a question. So, full disclosure, I'm a former MSF as well.
Oh, nice.
And I
What's your name?
Gwen.
Gwen.
I
We have met.
Yeah. I thought it was funny because I'm a psychologist, so I was always like the last one to leave a project because the trauma projects took too long, right? Everyone else wanted to move on to the next thing and be a logistician. But every day that in terms of humanitarian space shrinking, every day that I got out and played basketball with the local kids, like I felt more safe. So proximity has to be an element of this. And I think the retroflect, you know, of like one of our partners being backpacking medics on the Tiber border. They were facile and they were moving and they were mobile, but they were also kind of, it was simplified. I think the helicopter and the military, you know, like bunker and military type thing, there has to be obviously like this relationship.
I totally agree.
Yeah,
I totally agree, and that would be, you know, most akin to how MSF has always wanted to function and how it has remained safe. Yeah. The unfortunate issue that we face is like, how do you become friends with ISIL? You know, and yet there are people there that are, I'm sure, in devastating need of healthcare.
And then, you know, like before we pivot off our own soil, you know, the parallels of inner city Chicago and our police forces and kind of in their cars and not engaging with the community. I think, you know, there's this idea of like, what is happening here? And
exactly, yeah. It's a perfect parallel that we face here in our own inner cities. That's good to see. I think I met you at a dinner party.
Yeah, yeah, it was. No, but and courage. You saw a lot. I'm sorry.
Brought back good memories for you.
Yeah, you saw a lot.
In that case, in a civil war, the only solution is going to be political.
The only what?
Solution is a political solution, especially like South Sudan. No one's going to do a knockout fight. Have you ever thought that by having some medical care there, it may just be prolonging the conflict rather than, in other words, if the price that people had to pay were acutely higher, then maybe they'd be more willing to settle the conflict? Is that ever?
So that absolutely, that has been a recurrent discussion in numerous MSF interventions. I think in the example of the South Sudanese Civil War, so in that case, who's bearing the brunt are civilians, right? And I'm not exactly convinced that that would be in the best interests of humanity. I don't think that the MSF intervention there is prolonging the Civil War per se, any more than food drops are prolonging the Civil War. I think that's simply ameliorating the suffering of the civilization. Where it did come to a fore was in Rwanda, okay, where we had MSF had a huge discussion about this in the Rwandan context, where it felt that I think appropriately so, that Western powers, Clinton foremost among them, was refusing to intervene in Rwanda to stop the genocide, hiding behind the fact that humanitarians were there, saying, They don't need us there. There are other humanitarian actors there that are helping alleviate the suffering. We don't need to intervene to stop. And that was an example where the only thing that could have stopped that would have been Western power intervention, and they were using the presence of MSF and other actors as an excuse not to be there. And MSF withdrew, and their rationale was, you do not stop genocide with doctors. That was their one-line statement for why they were pulling out. And they said that the international community needs to get their act together and get in there with peacekeepers or whoever it takes to stop it. So I think it's very context dependent. But absolutely, that discussion comes up not at all infrequently. We wonder whether by trying to help we're hurting. South Sudan, I'm not convinced that that actually is the case. I think that if we weren't there, I think it would be the war would be evolving along the same lines. The truth is that the West doesn't care about South Sudan, right? I mean, there's no help coming if we leave there.
The person who would want South Sudan was Mickey Richard. She was one of the first people that was, I think it was, no, it was international money that was working in South Sudan. But I guess what I was referring to was not the work in the UN, but this concept that you raised of global Humvees that would go out, would go out more in terms of the areas where there was fighting and providing care to soldiers.
Yeah, I mean, I think a lot of the people that are getting injured there are civilians. But it's just, I mean, certainly I'd say, yeah, I understand what you're saying. A lot of the patients I treated in the surgical ward were military casualties. In fact, there's sort of amongst the population, they actually called I was with MSF Amsterdam. They get called the Noor MSF, which MSF would just cringe to hear, since you're not supposed to be partisan, or but because we were in the camp with the Noor, that's what the rest of the population called us. So that's the Noor MSF. They're there to help them win the battle, right? So we did a big part of our project was outreach. We had an outreach worker who I think was extremely brave, and she would go out every day, out the walls into the community to look for people who were sick, like Dinka who were sick, and then encourage them to come to the hospital. But then the Dinka didn't want to come to the hospital because they didn't want to come into the camp where all the Nuer were, right?
Do you have Dinka staff?
I never really asked. I never asked who is Dinka, who is Nuer. So, I mean, the majority, I'm sure, were Nuer because they're all sourced from inside the camp. So, yeah, it's always a dilemma. Any humanitarian intervention, whether it's MSF or anybody, you have to ask whether you're hurting by trying to help. Well, thanks a lot. Yeah, I appreciate it. Thank you for the opportunity.